Dr. Andin and Dr. Dayinta. Thank you very much.
Matur nuwun, dokter.
Yeah.
Assalamualaikum warahmatullahi wabarakatuh. Shalom, Om Swastiastu, Namo Buddhaya, Salam Kebajikan Rahayu. Let us praise and give our utmost gratitude to Allah Subhanahu wa Ta'ala for His mercy and blessing we could gather in this very special occasion. Good morning and welcome our speaker, Professor Zil Falil bin Alwi, MBBS, Master of Science, Master of Medicine, Pediatric, PhD, FEEMN, Senior Consultant Pediatrician and Clinical Genetics School of Medical Science, University Science Malaysia. Dr. Nyoman Suci Widya Siti, Master of Health, Clinical Pathologist Consultant of Hematology and Immunology, the Head of Clinical Pathology Residency Education Program, Faculty of Medicine, Universitas Diponegoro, Semarang. Dr. Dwi Retnoningrum, Clinical Pathologist Consultant, the Head of Clinical Pathology Department, Faculty of Medicine, Universitas Diponegoro, Semarang. Dr. Meta Hendrianing Tias, Master of Biomedic, Clinical Pathologist Consultant, a Teaching Staff Faculty of Medicine, Universitas Diponegoro, Semarang, as well as the moderator of today's guest lecture. The Honorable Staff of Pediatric Department and Biomedical Magistrate, Universitas Diponegoro, Dr. Karyadi Central General Hospital, Semarang. Our respected professors, attending doctors, and fellow residents, and all the audience, thank you for coming here today. Praise to God the Almighty, we have been graced by the chance together in this very special occasion. A virtual guest lecture of Clinical Pathology Medical Faculty, Universitas Diponegoro, Semarang, Laboratory Investigation in Pediatric Genetic Disease. All diseases have a genetic component, including pediatric disease. Those conditions are common, accounting for around 50% of pediatric hospital admissions. Genetic testing has to be learned and understood as it is vital to the diagnosis, treatment, and prevention of pediatric genetic disease. Clinical Pathology Medical Faculty, Universitas Diponegoro, Semarang study program seeks to add the latest knowledge related to challenges in laboratory investigation to pediatric genetic disease by inviting a guest speaker, Professor Zil Falil bin Alwi, MBBS, Master of Science, Master of Medicine, Pediatric, PhD, FAMN. We hope that this event can provide new insight and knowledge in the utilization of laboratory investigation in pediatric genetic disease in the future. To begin with, let's start by sending our prayers. Prayer begins. Finish. Before we proceed to the main event, I would like to inform you about our agenda today. First, the opening speech from Dr. Nyoman Suci Widya Siti, Master of Health, Clinical Pathologist Consultant, the Head of Clinical Pathology Residency Education Program, Universitas Diponegoro, Semarang. Lecture from Professor Zil Falil bin Alwi, MBBS, Master of Science, Master of Medicine, Pediatric, PhD, FAMM, about laboratory investigation in pediatric genetic disease. Moderated by Dr. Meta Hendrianing Tias, Master of Biomedic, Clinical Pathologist Consultant. And then discussion. After that photo session, and finally closing statement. The participant of this lecture will be given a certificate by filling the required data on the attendance link in the chat section. The first attendance link is now open. Also, there will be a second attendance link which is open at the end of discussion. The next agenda is opening speech from Dr. Nyoman Suci Widya Siti, Master of Health, Clinical Pathologist Consultant. The Honorable Dr. Suci, the time is yours.
Thank you, Dr. Dayinta. Okay. The Honorable Professor Dr. Zil Falil bin Alwi, Senior Consultant Pediatrician and Clinical Geneticist from School of Medical Sciences, University Science Malaysia. The Honorable Professor Dr. Lisyani Suromo, Clinical Pathology Consultant. The Honorable Professor Dr. Banundari Rahmawati, Clinical Pathology Consultant. The Honorable Dr. Dwi Retnoningrum, Clinical Pathology Consultant, Head of Clinical Pathology Department, Faculty of Medicine, Universitas Diponegoro. The Honorable Staff of Clinical Pathology Department, Pediatric Department, and Master of Biomedical Department, Faculty of Medicine, Universitas Diponegoro. the students, and all participants. Assalamualaikum warahmatullahi wabarakatuh. Good morning. First of all, let us give praises to Allah Subhanahu wa Ta'ala who has given us blessings and mercies so we can attend this lecture in good conditions. On behalf of Clinical Pathology Residency Educational Program, Universitas Diponegoro, I'm deeply honored to welcome our special guest, the Honorable Professor Dr. Zilvalil bin Alwi, Senior Consultant Pediatrician and Clinical Geneticist from School of Medical Sciences, University Science Malaysia. We would like to express our gratitude and high appreciation to Prof. Dr. Zilvalil bin Alwi for kindly accepting our invitation despite his busy and tight schedules. Thank you, Professor. Guest lecture or visiting lecture program is one of our program in the Clinical Pathology Residency Education Program, Faculty of Medicine, Universitas Diponegoro, Semarang, Indonesia, in order to develop our students' knowledge and quality. We invite professors and experts from various universities in Indonesia and also from overseas to share and discuss various topics in their expertises. This year, we have already conducted for a guest lecture program with invited speaker from Clinical Pathology Department from Universitas Gadjah Mada, Universitas Brawijaya, Universitas Airlangga, and from Dharma Is Hospital. Today's lecture is the second guest lecture from overseas lecturer, and we do hope that in the future we can conduct this program routinely. We also hope this lecture become a good start and opportunity for us to maintain networking and collaboration between University Science Malaysia and Faculty Medicine Universitas Diponegoro, particularly with the Clinical Pathology Residency Program. We also looking forward that in the future, Prof. Dr. Zilvalil bin Alwi can meet us and visit our faculty in Semarang, Indonesia, not only through a virtual meeting. Okay, and the topic in the visiting lecture today is about laboratory investigation in pediatric genetic diseases. As a doctor and clinical pathologist, we have to study laboratory investigation in genetic diseases and moreover update ourselves for advanced genomic medicine. I hope this special guest lecture will improve our knowledge about the steps of laboratory diagnostic and pediatric genetic diseases for better management of the disease. For the participant, thank you for joining the program and have an enjoyable and fruitful lecture. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh. Thank you.
Thank you, Dr. Niyama Susiwidya, Master of Health Clinical Pathologist Consultant. To all participants, please fill in the attendance link which can be accessed in the meeting chat. Ladies and gentlemen, the next agenda will be led by Dr. Meta Hendrianitya, Master of Biomedic Clinical Pathologist Consultant. Allow me to read her curriculum vitae. Dr. Meta Hendrianitya graduated as a general practitioner and clinical pathologist. She finished her Master of Biomedic Health and Medical Science program from Universitas Diponegoro, Semarang. She also achieved consultant of endocrinology and metabolism and infectious disease from Universitas Diponegoro, Semarang. She is currently working as clinical pathologist and medical support manager at Diponegoro National Hospital, Semarang. She is also a doctor in charge at Prodia Laboratories Setiabudi. She is active as a lecturer at the Clinical Pathology Department, Faculty of Medicine, Universitas Diponegoro, Semarang. To the Honorable Dr. Meta Hendrianitya, the time is yours.
Thank you, Dr. Dayinta, for your time. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera, salam sehat untuk kita semua. Om Swastiastu, Namo Buddhaya, salam kebajikan, Rahayu. Sebelumnya kami ucapkan terima kasih kepada para senior kami, juga rekan sejawat, dan juga yang terutama adalah PPDS kami tercinta pada kegiatan guest lecture kali ini. Good morning everyone. Good morning, Professor Zilvalil. Introducing myself. My name is Meita Hendriani Tias. Welcome to our scheduled guest lecturer activity of the Clinical Pathology Study Residency Program of Faculty of Medicine of Universitas Diponegoro. I will be a moderator in this event and guide this exciting guest lecture with topic laboratory investigation in genetic pediatric disease. I'm so honored, Professor, to have the opportunity to introduce our speakers. Professor Zilvalil bin Alwi, MBBS, Master of Science, Master of Medicine Pediatrics, PhD. First of all, thank you for your time to give us to improve our knowledge about this lecture about laboratory investigation in genetic pediatric disease. And before entering the presentation, I will read Prof. Zilvalil's curriculum vitae. His education history are Master of Medicine Pediatrics at University Science Malaysia, Master of Science in Medical Genetics, University of Glasgow, United Kingdom, PhD in Pharmacogenetics, University of Aston, United Kingdom. And he also joined several organizations such as UNESCO Chair on Human Genetic Thalassemia, World Health Organization Technical Advisory Group on Genomics, Malaysian Note of Human Variome Project, Board of Director of Human Variome Project International, Global Globin Network, Scientific Advisory Committee and the Gene Disease Specific Database Advisor, Council of Human Genome Organization, Genetic Counseling Subcommittee of the Hugo Education Committee. And his work experiences is also very interesting, Prof. As a senior consultant, pediatrician, and clinical geneticist at Human Genome Center, School of Medical Sciences, University Science Malaysia, Kota Baru, Malaysia, as a chief editor of several journals, including Malaysian Journal of Pediatrics and Childhood, also a council member of the College of Pediatrics Academy of Medicine of Malaysia. He is also advisor for the Genetic Pathology Specialty Committee of the College of Pathologists, Academy of Medicine of Malaysia, and also founding president of the Malaysian Society of Human Genetics. Before we enter the presentation to our participant, please make sure your Zoom is on mute mode, and we have scheduled time for question after this presentation, or you can write your question via Zoom chat. For Professor Zilvalil bin Alwi, time and screen is yours.
Thank you very much, Dr. Mita. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
First of all, I'd like to thank Dr. Norman, especially, and the organizing committee for inviting me to give this guest lecture. My visit to Undip was a very long time ago. I think about it must be 10 years ago. And after that, I always meet colleagues from Undip regularly during meetings, especially during the INA SAG meetings or conferences organized by INA SAG. So I cherish very much my ties, my network, my collaboration with colleagues from Undip, and I am deeply very honored to be given this opportunity to share my knowledge in this lecture especially with the students. So can I share I will share screen. I am not able to share my screen.
Please wait, Prof.
Do you have a copy of my slide?
Yes, we have a copy for your slide. Wait for a second, Prof.
Uh, Let me try to share the screen. Can you give me a minute? Can I control the screen?
Can you see the screen?
Yes, I can see the screen, but I cannot control the screen. Can you let me share my slides so that I can control?
Wait for a minute, Prof.
Yeah. Then can you unshare and yes, okay.
Can you try to share your screen again, Prof?
Yes, yes.
Okay.
Can you see it now?
Yeah, we can see it.
Okay. Thank you.
Thank you. Alhamdulillah.
Okay, thank you very much. So the topic is about laboratory investigations for pediatric genetic diseases, but this my lecture will also cover not just pediatric diseases, but genetic diseases, and the focus actually is on the laboratory investigation, the genetic investigation for for diagnosis of genetic diseases. So when we talk about genetic testing, we mean that we mean to the use of laboratory tests to examine a patient or an individual's DNA for mutations or variations, and perform in the context of medical care, ancestry studies, or forensics. But in our context today, for this lecture, I will focus on the medical care or medical diagnostic. So when we do genetic testing, normally the aim is to, to confirm or to rule out a suspected genetic disease, and also to determine the likelihood of parents or the subject passing on the variant or the mutation to their offspring. And this is very important because the information is required when we provide genetic counseling to the patient and to the family. So we need to differentiate between genetic testing and genetic screening. So when we talk about genetic screening, we are talking about a population-based screening, which is performed to find the population, those in the population that carry the gene and the risk of developing a disease or a particular disease. But for genetic testing, we use the laboratory test for diagnostic purposes, to find the presence of the gene or the mutation or the variant in that individual or that patient that causes a particular genetic disease. So genetic screening is done on a particular population, while genetic test is done on an individual, more specifically on a patient and his or her family. And most of the subjects for genetic testing are individuals who are often symptomatic, whereas for genetic screening, it is done on asymptomatic individuals. And genetic testing involves the use of medical diagnostic tests as compared to genetic screening, where a simple medical or genetic test is used, which has a high rate of sensitivity, which will be able to pick up the variant which we are looking for. And normally genetic testing will lead to treatment option, but when we do genetic screening, the test we will need to do a further test, which is the diagnostic test for those patients who are tested positive. We need to reconfirm, with a diagnostic test. So for genetic testing, positive results provide a definite diagnosis, and for genetic screening, a positive test just indicates suspicion of the disease, but warrants confirmation, as I mentioned earlier. So the genetic testing is done when a person is suspected to have the disease, and this is further supported by a positive family history. And genetic screening, as I mentioned earlier, when the person or the population is tested because of possibility of having a particular disease due to the occurrence of such disease within a certain ethnic group. So when we talk about diagnostic genetic tests, there are many tests at the moment. As of end of last year, almost 200,000 genetic tests is available or has been submitted to the genetic testing registry, and most of these tests are actively being used, especially in the higher income countries. And it's very unfortunate that low and middle income countries like Malaysia, Indonesia, and many other countries in Southeast Asia, we are still lacking in our ability or infrastructure to perform genetic tests. So when we talk about genetic tests, it can be broadly divided into a molecular genetic test, which mainly is used to diagnose monogenic diseases. And there's another group which is called the cytogenetic test, which looks into the chromosome abnormalities. And the other group is the biochemical genetic test, which in our context today refers specifically or more towards the inborn error of metabolism. I will not go into inborn error of metabolism because that is by itself another lecture. In many countries, the inborn error of metabolism is part of the work of a genetic lab. But there are also countries where the labs are separated for inborn error of metabolism and genetic diseases. So when we talk about genetic tests, traditionally, we use diagnostic genetic tests for single gene testing. But now there are many tests available using a panel testing, which will be able to pick up more diseases, as well as to screen or to look for more possibilities or more differential diagnosis for the patient. And of course, I think the trend now is genomic testing, where the next generation sequencing or the whole genome sequencing has made it possible to look not just into one gene or a group of genes, but the whole genome. So this is, I think, the presence of genomic testing, the availability of genomic testing has revolutionized, medical care, and has afforded medical doctors to advance in terms of diagnostic and medical care. So when we talk about genetic tests, as I mentioned earlier, we look at one or a few genes at a time, but genomic tests allow us to look at thousands of genes at one time, and therefore yielding much more information that can be used in terms of for our patient, medical care for our patient. So there are 23,000 or 20 to 25,000 genes in our human genome. And of course, the idea, if it is possible, we would like to test all these 23,000 genes, in one go, so that we will be able to get more information about our patient, not just for the disease that we are concerned with or that we are treating the patient, but also to look at the possibility of our patient developing other diseases, maybe not now, but in the future. So by offering a gene panel test, we will be able to look for changes in a list or a group of genes. For example, a comprehensive panel care may include 300 to 400 different genes. And of course, instead of looking at the whole genome, we can also look at just the exome, where we can look at genes associated with a patient's conditions. Exome, as we know, are the protein coding region, and most genetic disorders are caused by mutation in the genes in these protein coding regions. And of course, if we have the ability, we have the means, we have the infrastructure, if we have the money, it is good that if we can perform a whole genome sequencing, which includes both coding and non-coding region, because this will provide much more information about our patient. So generally, a genetic test can be used to diagnose disease, to identify gene changes that are responsible for an already diagnosed disease. We can also use genetic tests to determine severity of a disease. And with this information, the doctors or the clinicians can use to decide the best drug treatment for a certain individual. We can also identify gene changes that may increase the risk of developing a disease. And we can also identify gene changes that can be passed on to the offspring. And this is very important because genetic tests should lead to a genetic counseling, and genetic counselors would require this information so that they can provide proper counseling to the families, especially regarding the inheritance of the variants or the mutation. And of course, I think now genetic tests are used to screen newborn babies for treatable condition. And I think this is the current trend. In the UK, for example, at the moment, they have started on a newborn genomics screening program, a pilot project for screening newborn using genomics. So medical genetics can be divided broadly into molecular genetics, mitochondrial genetics. We know besides our nucleus, our mitochondrial also contains DNA, and any mutation or abnormality in the mitochondrial DNA will lead to mitochondrial diseases. And then, of course, cytogenetics. This is the study of the human chromosome. And now cancer genetics, which is actually a part of multifactorial genetics. Cancer genetics now is grouped on its own. So it is originally part of a multifactorial genetics where there is an interplay between the genetic factors and the environmental factors. So soon, the multifactorial diseases the aim is to get these multifactorial diseases into the mainstream of medicine, meaning that even though now when we talk about genetic diseases, genetic diagnosis, we talk about the monogenic diseases or the mitochondrial diseases or the cytogenetic or the chromosomal disorders. But soon in the future, we hope that all diseases which has a genetic factor, for example, diabetes, hypertension, bronchial asthma, so all these would be able to be practiced in the mainstream. For example, when patient comes to a clinic, the first step that a doctor will do is to test or to check patient's DNA, so that the doctor will have an information about the diseases that the patient is susceptible to, and as well as the drugs which the patient would be able to respond to. So that is the aim or the goal of genomic medicine. So I will start first by discussing about cytogenetic tests. So cytogenetics is the field of studying chromosome structures and its composition, and it is to detect abnormalities of human chromosome, abnormalities in the abnormalities in the structure, as well as numerical abnormalities. So examples where cytogenetic tests are being done includes babies with ambiguous genitalia, newborn with birth defect. Normally, the first line for screening of a baby with birth defect is to look for any chromosome abnormalities. And of course, babies with dysmorphic babies, especially facial dysmorphism, undiagnosed syndromes. So normally, the first line of investigation would be to do a cytogenetic test or a karyotyping. And of course, couples with infertility. Some of the causes of infertility includes chromosome abnormalities in either the husband or the wife. So couples with infertility are normally subjected to chromosomal studies. And also babies with mental retardation or learning disabilities. Normally we screen for chromosome abnormalities while looking in particular for Fragile X syndrome. So most of the cytogenetic tests are being done using peripheral blood, but we can also use, besides the peripheral blood, we can also use bone marrow or amniotic fluid to perform chromosomal studies. Chromosomal analysis would be able to detect gross abnormalities, either numerical abnormalities or structural abnormalities. But to look for defects or abnormalities which are smaller, we can also perform cytomolecular studies, which includes FISH, or fluorescent in situ hybridization, CGH, a comparative genomic hybridization, or an array CGH. So karyotyping, as I mentioned earlier, would be able to pick up just the gross abnormality. FISH would be able to pick up the micro deletion, and CGH as well as array CGH would be able to pick up more screen for more abnormalities, smaller size abnormalities, which will not be able to pick up by the conventional karyotyping. So many of my patients, the samples that we receive at USM involve patients or babies with ambiguous genitalia. And of course, I think the first line of investigation to look for to determine the gender of a baby with ambiguous genitalia is to do a karyotype to look for XX or XY chromosome. We also receive a big number of samples for the three most common trisomy, which is the trisomy 21, trisomy 18, or the Edwards syndrome, and trisomy 13, which is the Patau syndrome. So karyotyping require harvesting and culturing of the cells, which takes time, normally between 5 to 7 days. But for cases when patients are suspected to have trisomy 18 or trisomy 13, the doctor will request for an urgent karyotyping. Mainly, they want to decide whether the baby has either an Edwards syndrome or a Patau syndrome. A baby which is confirmed to have a trisomy 13 or trisomy 18 would have a very poor prognosis, and normally the managing doctor would prefer not to resuscitate the baby. So they would request for an urgent karyotyping, which we normally perform within less than a week. So CGH would be able to detect chromosomal copy number changes, loss or gain, without the need for cell culturing. So this, we will be able to screen faster, as well as a broader screening for any abnormalities. currently the best technique for screening for chromosomal abnormalities, especially smaller defects, is by using array CGH. Array CGH would be able to evaluate areas of the human genome for gains and losses, deletions or duplications of chromosome segments at a higher resolution. And they are able, using this technique, we are able to detect small chromosome abnormalities across the whole genome in a single test. And it is able to detect any gain or loss of DNA that is 80 kilobases or larger. So the array CGH cannot detect deletions or duplications that are smaller than 80 kb or mutations within genes. So if the karyotyping result comes back as normal, and the doctors still suspect that the baby has a gross abnormality and most likely to have a chromosome abnormality, then we would then perform the array CGH, which would be able to pick up much smaller abnormality or loss or gains of the DNA. Now, if the array CGH comes back as normal, and again, the doctor still suspect that there is abnormality or there are abnormalities in the patient, in the genome, then we will subject the patient to a molecular study. Depending again, if a particular syndrome is suspected, we would then perform a molecular study or molecular test for that particular syndrome. So this is just to show you the array CGH with a significant finding at chromosome 8 with a gain involving 97 genes. So normally, we would then provide information about on these 97 genes and try to correlate, the function of these genes and the abnormality that are found, abnormalities that are found on that patient. So array CGH is able to explore all 46 chromosomes in a single test and to detect any DNA imbalance, including loss or gain of chromosome material, and able to detect chromosome balances. There are no clues as to what the chromosome anomalies might be. So especially where in patients with an undiagnosed, unrecognizable syndrome, a baby with an unrecognizable syndrome, or a dysmorphic baby with a syndrome. So array CGH is also able to simultaneously detect aneuploidies, deletions, duplication, amplifications, possible also for babies suspected to have idiopathic mental retardation or any group of abnormalities. And the next group is molecular diagnostic tests. So using molecular diagnostic tests, we are able to analyze DNA sequences for variants or mutations that can pinpoint to the potential emergence of a specific disease. So the aim of using this molecular diagnostic test is to diagnose and also to monitor disease and also to detect risk of developing the disease. And ultimately, molecular diagnostic test is used to provide the basis for personalized medicine or precision medicine. So all of you here are most welcome to visit University Science Malaysia in Kota Baru. We have our Human Genome Center at the School of Medical Sciences, University Science Malaysia, and we provide as well services, molecular genetic services, as well as cytogenetic services. So these are the list. So these are the list of tests that we offer at our Human Genome Center. At the moment, we do not provide any genomic tests, mainly because I think it is more cost-effective to to outsource these tests from other labs. But if any of you, we welcome collaborations of those who wish, to send samples, as well as students who wish to, to learn more about this test. Now, I mentioned earlier about gene panels, and these are collection of genes that has been grouped for genetic testing, which can simultaneously sequence a particular disease or a particular phenotype. For example, if patients with developmental delay or intellectual disability, or patients which we suspect could have autism, so we can use a panel for intellectual disability, which includes 264 primary genes associated with autism and intellectual disabilities. So using a gene panel, we would be able to, to pick up diagnosis much more efficiently, especially for babies which presents with a particular phenotype. So there are more than 1,200 panels available in the market. I've listed here just some of the panel. Now, besides intellectual disability gene panel, there's also a gene panel for hearing loss, and also a cardiomyopathy panel, a cystic kidney disease panel, and myeloid leukemia panel. So there are, as I mentioned earlier, there are more than 1,200 panels. So using gene panel is a very efficient way, to provide a genetic diagnosis to our patients. And of course, I think the most efficient method or approach for diagnosis of our patients would be using next generation sequencing. And I think this is a very good technology, and using genome sequencing, we would be able to obtain much more information as compared to just studying a single gene or just a group or a panel of genes. So using whole genome sequencing, we are able to diagnose most of the more than 6,000 conditions listed in the OMIM database. These are the genetic diseases. Of course, if we have the means, we have the infrastructure, the capacity, and of course the money, I think this is the way forward. This is the future for medical diagnostics. And of course, I think if we have limited funding and we have a patient which we do not have a diagnosis with a normal karyotype, with a normal array CGH, we can subject this patient to whole genome sequencing, which looks into just the exon. And it is, even though it is not so expensive as compared to whole genome sequencing, but it offers a cheaper, if you like, cost, and also a more affordable means for many labs. So basically, whole genome sequencing allows examination of SNV, indels, SV, and CNV encoding and non-coding regions of the genome, compared to full exome sequencing, which targeted to just the protein coding regions, which represents less than 2% of the genome. So ultimately, as I mentioned earlier, the idea of doing a diagnostic test, is to provide the basis for personalized medicine or precision medicine. We need to start the molecular profiling of our patients so that we can then proceed, or we know what is the basic DNA abnormalities present in that patient. And also this is important, as I mentioned earlier, for pharmacogenetics. But I wish to highlight here also, this is very important for prenatal screening. So reproductive genomics is relatively a new area, which I think is gaining importance. So as medical understanding of genetic variation increases, genomic technologies provides hope for assisted reproduction. So this is very important, especially for couples who are known to be carriers for genetic abnormalities or genetic variants. So they would, we would be able to provide them assisted reproduction, and hopefully we would be able to provide them the chance of having a normal child or a normal offspring. So the reproductive genomics also allow options for prevention of genetic diseases. A carrier couple may consider in vitro fertilization with pre-implantation genetic testing, or PGT, to prevent passing on the disease to their offspring. So pre-implantation genetic test, or PGT, is a technique used to identify chromosome genetic abnormalities in embryos created through in vitro fertilization before pregnancy or before in the mother's womb or the mother's uterus. So it provides an alternative to current post-conception diagnostic procedure, which many centers use amniocentesis or CVS disease prior to implantation. So PGT is indicated for couples who are carriers for genetic diseases, and those who already have a child with a genetic disease. So it's also for mothers, abortion or recurrent abortion. A patient with previous genetic disease, as I mentioned earlier, repeated implantation failure, carriers of chromosome reorganized into PGTA, which refers to techniques where embryo are screened for aneuploidy, and PGTM, which refers specifically to when one or both genetic parents has a known abnormality, and testing is performed on an embryo to determine if it also carries a genetic abnormality. So and the third type of PGT is PGT-SR, which specifically screen for structural rearrangement of chromosome, such as a balanced translocation. So PGTA detects embryos with abnormal chromosome, the aneuploidies. So it allows identification of embryo with the correct number of chromosomes. So normally for PGT, the IVF is done in four or five test tubes, and each of these test tubes, each of the embryos, each of the embryo is then subjected to PGTA, which detects embryo with the abnormal chromosome. So and the normal chromosome. So only the embryo with the normal chromosome is then implanted in the mother's uterus. For PGTM, this allows detects those diseases or abnormalities caused by the mutation. We suspect a monogenic disease, such as sickle cell disease, thalassemia, or cystic fibrosis. So while the PGTA detects mainly the chromosome abnormality, PGTM detects those with the monogenic diseases. And PGT-SR detects structural chromosome abnormalities. So those embryos with chromosomal structure abnormalities such as translocation, inversion, insertion, duplications, will then be discarded, and only the embryo with a normal chromosome is then implanted in the mother's uterus. So ultimately, as I mentioned earlier, the aim is to provide our patients with personalized or precision medicine. So this is the way forward, and I think the future is precision or personalized medicine. And even though countries like Malaysia is still far away from achieving genomic medicine or personalized medicine, the first step is to provide a molecular profiling of our patient. So this is something which I think we can aim at the moment. So all our patients with genetic diseases, molecular profile. So for example, a patient with thalassemia, at the moment, you do not need to do a molecular test to diagnose thalassemia. The conventional method for diagnosing thalassemia, as you are aware, is by using the full blood picture or the complete blood count, followed by the CE or the HPLC. So you do not need to do molecular testing to diagnose. Only in certain cases, you need to resort to molecular profiling. However, if we have a molecular profile, we would be able to provide the first step or the base for the future treatment of this patient, in the era of genomic medicine or personalized medicine. So I'm very happy to know that Indonesia has also identified or recognized genomics to be an important area. And I believe your minister have launched this last year, the Indonesian National Genome Project. So Malaysia has not launched yet a genome project. So Indonesia actually is much ahead of Malaysia in this aspect. So this is just my last few slides. I'd just like to mention about gene therapy. So I will not talk about gene therapy. This is a lecture on its own. But I just like to highlight the fact that gene therapy is now available in the market. It is very expensive, but it is available, and we can start thinking about treating our patients with genetic diseases. Patients, like thalassemia patients, already we have the gene therapy approved, the drug Zintaglo approved for people with beta thalassemia, and also the Casgevy. This is also another gene therapy using CRISPR for patients with thalassemia. So the future is here. It is available. Of course, it is expensive, millions of dollars. The cost is millions of dollars for a gene therapy, but we should not lose hope. We know that it is available, and we need to start preparing for now. And Indonesia is lucky because the minister, the government, has recognized genomics to be important, and I think you all are in the right step to be heading towards genomics. So the idea or the aim is to provide genomics for everyone, especially from those from low and middle income countries. So genomics is for all and no one, especially those from Indonesia, from Malaysia, should be left behind. Thank you very much.
Okay. Thank you very much, Prof. Silvalil bin Alwi. This is so interesting presentation, Prof. Your knowledge is, oh, wow. We hear your presentation in here, but we try to understand from A to C about your presentation in here. So now we enter the discussion session, Prof. There are already written question via chat. The first question is from Dr. Dayinta, our MC,
Okay.
Prof. Good morning, Prof. Silvalil. On what gestational age would be the best time for perform cytogenetic testing through amniotic fluid?
So I think the best person to answer this is an ONG specialist, the obstetrician. But I believe it is, you can either use amniotic fluid or CVS. So I always get this confused. So this is, I think, between 12 to 14 weeks, if I remember correctly. So so you can perform amniotic, you can take the amniotic fluid during this time, and you can send it to the cytogenetics lab for the cytogenetic testing. Yeah. So this has been practiced, I think, been used for many years now. But like I said, if you have the ability or the means to do a PGT, pre-implantation genetic diagnosis, you do not no need to wait for the couples for the couple to get pregnant. So the couple, if they plan to get pregnant, they can use the PGT, which involves IVF, taking the husband's sperm and the wife's ovum, do perform the IVF in a test tube, 4 or 5 test tube, and then select which embryo, is normal, and which embryo has the abnormality, the chromosome or the gene abnormality, and you exclude that embryo, and you take only the embryo with which is normal, and you implant that, and you get pregnant. So I think that is the best way. So of course, amniotic fluid, you need to wait for 12 to 14 weeks, and during this time, you need also to decide whether to continue the pregnancy. The patient needs to decide whether to continue the pregnancy or to abort. So time is very crucial, because if you want to abort, you need to abort before 120 days. Yeah. So I hope that answers the question.
Yes, thank you, Professor. But
Thank you, Professor.
you can type second question. Second question is
So I mentioned PGTA, PGTM, and PGTSR. How are these should be applied? I think I answered this. Is one test more prioritized than others? Well, it depends. If the parents is a carrier for example, for thalassemia or for SMA, spinal muscular atrophy, so you need to do PGTM because you need to do a molecular test to look for whether the embryo has SMA. So SMA is diagnosed by using a gene test, a molecular test, not a cytogenetic test, not a chromosome test. So if you suspect, if you want to screen the baby or the embryo for a monogenic disease, we need to do a PGTM. But if we want to screen the patient or the baby for chromosome abnormality, for example, to look for any trisomy 13 or trisomy 18, then we need to do a PGTA. So sometimes the mother or the father is a carrier for a chromosome translocation. So then we need to do a PGTSR to look whether the patient, the baby or the embryo carries the chromosome structural abnormalities. So it depends on what disease that we want to look for.
So we can choose one of them, depend on the disease, Prof.
Yes,
Okay.
yes.
Thank you for your answer. There is no one priority from others.
It depends.
Depends on
It depends on
the,
what disease actually. Yeah.
okay.
So if your patient is interested more in looking for monogenic disease, then PGTM should be the one to test.
Okay.
That is
Yeah,
important.
we
Yeah.
understand your answer. Thank you, Prof. Next
Yeah.
question, please. Yeah. From Dr. Marcel, good morning. Prof. Silvalil, why should we check the non-coding sequences of the DNA, and those sequences do not code amino acid?
Yes, okay, thank you. I think this is a very good question because, of course, the main area in the DNA is the protein coding region. But of course, we know now that even the non-coding region also carries variants, which is associated, which are associated with severity of the disease, for example. So by knowing what variants that are present in the non-coding sequences, sometimes this variant can determine or influence the disease progression or the disease severity of that particular condition. So that's why sometimes, depending again on what disease, what information, prior information, data, literature review that we have, we can look for variants in the non-coding region. So this is what we call a disease modifier, variants that causes a disease, variants with disease modifying effect. So yeah, this is one of the reasons why we can check, or we need to check non-coding sequences as well. Yeah.
Okay, thank you for your answer, Professor. The next question, please. Okay. The next question about chromosome analysis, Prof. Which sample is better between blood and bone marrow?
Okay, this is a good question also. It depends. For example, if you have a baby with birth abnormality or with dysmorphic features, undiagnosed syndrome, so the best sample would be to get the baby's blood, not the bone marrow. Now, if you have a baby or a patient which you suspect to have cancer, malignancy, then the best would be, especially blood malignancy, the best would be a bone marrow sample. For example, leukemia, lymphoma. So it is better to get the bone marrow specimen to look to perform the karyotyping. But of course, if you have a baby, dysmorphic babies with abnormality, Down syndrome, a Patau syndrome, so then blood is much better. So it is easier to perform chromosome analysis on blood because bone marrow requires a more challenging skill. For example, at the Human Genome Center, University of Science Malaysia, when we have a new staff, a new technologist, a new lab technologist, we will then ask that staff in using blood only when he or she is comfortable or is able to perform blood specimen, then only we will allocate him to do the bone marrow. So it's more challenging, bone marrow.
The next question, please. Thank you, Professor, for your explanation. The next question. Okay. From Dr. Irma, is there any laboratory screening test for specific learning disabilities such as dyslexia or dyscalculia? Thank you, Professor. Thank you for your answer before.
Okay, this is a difficult question. So dyslexia, I'm not sure. Dyscalculia, dyscalculia, I think problem in calculating. I think dyslexia, I am not sure actually. I know patient with learning disability, like I mentioned in one of my slides, there is genes associated with learning disability. So, but for dyslexia, I'm not really sure. So, but this is a good question because there are many children now with dyslexia, and I think some doctors are also asking if there is a specific test. But we tend to subject students with dyslexia to the same gene panel as learning disability. So I think I put it. I put this as there is a slide.
Yeah, maybe about uh, uh, gadget from gadget is also can use every day for children. Can this is can
Dr. Mehta, sorry, what did you say?
yeah,
Agent.
yeah, about gadget. This is can affect dyslexia and dyscalculia also, Prof. Not only genetic, but also about their environment for children. Maybe, I don't know.
Maybe.
Yeah, let's move to next question, Prof. Sorry, that's only out of topic, Prof. Dr. Tika, from Dr. Tika, when would be the best time to test our molecular profile, Prof? I'm sorry, Prof.
Sorry,
Yeah.
can you hear me now? So when would be the best time to test our molecular profile? So this is well, I'm not sure how to answer this, but well, I assume that when you say our molecular profile, it's a normal person. You, me, we assume we are normal. So should we test our molecular profile? Yes. Why not? I think during the era of personalized or precision medicine, when you go and see a doctor, the first thing the doctor will do is to test your genome, just to run. Take a drop of your blood or your saliva, put it on a kit, and within a few minutes we'll be able to get your genomic profile and we'll be able to tell what drugs can you respond, what drugs can you not respond, and also if you will develop in the future cancer or other diseases. So this is the era of precision medicine. So in order to achieve this, all individuals should have their molecular profile done or genomic profile done. So the best time, I think so, in order for the future, the best time would be screening our newborn for genomic profile. All newborn should be in the future in their identity card them, and when they go and see a doctor, they can let the doctor test it. So in the future, hopefully, that all newborns will have a genomic profile or genomic screening done, so that they have throughout their life carry their genomic profile maybe in their identity card or in whatever form, in a bank, their own bank, for example. Yeah. So then I think then we can talk about precision medicine. So precision medicine will not be useful if you do not know your genomic profile. So it cannot be applied. You need first to know what is your genomic profile, so that the doctor will be able to tell you what treatment or what drug is the best for you. So it's the newborn. I think the answer is
How
newborn.
about adult,
Dr.
Prof?
Tika.
How about
This is my
adult?
opinion.
Me, for
Please,
example.
yeah, but please remember that screening newborn is controversial because they do not have, they are not able to give their consent, to take their DNA. So there are many ethical issues. There's also a question of storage of this information. So who is the owner of this? Is it the parents or is it the baby himself? So there are many ethical issues involved. But in terms of concept, I think the idea is to get this newborn to be screened. So that is my opinion.
Yes.
Thank you.
Your answer is there. One question from private chat. How about the ethics about pre-implantation genetic testing in your country, Prof? Is it allowed by your government? This private chat to my message from Dr. Nurmalia Palembang.
Yes.
If you find any
Thank you.
genetic problems,
Yeah.
how it's handled? Is
Yes,
it
yes. Thank
allowed
you.
to? Yeah. Thank you. This is ethic problem, Prof.
Yes. Thank you very much. This is a very good question. Very good question. So, pre-implantation genetic testing in Malaysia, it is available mainly in the private hospital in Kuala Lumpur. It is expensive, so it is allowed. But like I said, to get first you need to do IVF. So if it is just IVF, you need just one test tube. But for PGT, you need to do normally 4, 5, or 6 test tube. And the ethical issue is when you need to choose just one embryo, one out of maybe 4 or 5 or 6 embryo that has been produced. And what happens to the rest of the embryo? Normally, it is discarded. So it is not. Many people think it is not ethical to discard this embryo. The unused embryo. So this is the ethical issue. I do not have an answer. Whether what is the best way to handle this, but the point is, through PGT, we are able to provide couple with the chance of having a normal child. So normally couples who are approved to do PGT are those couples which already have one child with with a fatal genetic disease, for example SMA. So the couple has a child with SMA type 1, which the couple see that the baby dies within a few months. So they're very sad, very sad experience for them. And when they have a second child, the second child also has SMA. So and the child also died within the next few months. So then they want the opportunity to have a child who is normal. So then of course I think they have the opportunity of using PGT to do this. So in this case, in cases like this, normally it is justifiable for them to perform PGT. So remember, some centers they misuse unethically. They misuse the PGT by offering the selection of gender. So many couples, for example, certain ethnic group, they prefer baby boy. So they are willing to pay the private hospital to do PGT, pay a lot of money just to get a baby boy. They are not carriers of any genetic disease. They are not at risk of any genetic disease. So PGT is done for them just to select the embryo with an XY, a male embryo, so that they will get a boy. So this is the unethical practice, which I think may be present, may be happening in some sense. So yeah, so I hope that answered the question. So yeah, for the second part, if you find any genetic problem, Well, you are right. It is not 100% successful. The success rate is, I think, is more than 50%. Quite high, but it's not 100%. So sometimes there's failure. If it fails, is it allowed to terminate the pregnancy? So again, I think this is again a very sensitive issue. I do not have the experience of having a patient like this. So I'm not sure what is the best way to handle it.
Yeah, it's difficult to answer, Prof, about the ethics, and also because it's by by our government and your government, it's maybe different different rule in our country and your country. But I will continue the question about before questionnya yang tadi jangan di
Ya.
masih yang tadi.
Okay, Dr. Lucy, ya.
No, about this pre-implementation genetic testing, Prof. I will ask you more about this. You mentioned that pre-implementation testing is done in vitro fertilization, Prof. So we can choose the normal structure for the embryo. How if pregnancy in normal pregnancy, but not in vitro fertilization, we cannot choose the normal embryo.
Yeah.
But we can only screen from amniotic fluid or from filicorialis, Prof. Sorry about that. How pregnancy
Well, I think it is
yeah.
indicated, not indicated for normal pregnancy, Dr. Mehta.
Oh,
So, like I said, some
only
centers,
in vitro fertilization.
yeah, in vitro fertilization, yes. No,
So in
it's not.
normal pregnancy, we only can screen from amniotic and or from mother blood or something like that, Prof?
Yes.
Okay.
Yes.
Yeah.
Yes.
Okay, thank you, Prof, for your explanation. Next question, please. 9. If there is an abnormality chromosome in pregnancy, is it acceptable in Malaysia law to end the pregnancy? It is the last question. It's the same. And the second, in the case hematological malignancy, if the bone marrow is hypocellular, is there a need to prepare how many minimal cells numbers to be used for abnormalities in gene or chromosomal testing? Thank you.
Okay. This is a tough question. So the first one, if there is abnormality chromosome in pregnancy, well, in Malaysian law, we are not allowed to do abortion unless the pregnancy is life-threatening, both to the mother as well as to the baby. So this needs to be certified by 2 independent specialists. Only then abortion is allowed, termination of pregnancy is allowed. So even if there is abnormality, the law requires the advice or the certification or the confirmation or recommendation by 2 specialists, 2 independent specialists who will recommend termination of pregnancy. But otherwise, it is not allowed to do abortion in Malaysia's law. even though it is the baby, the fetus is abnormal. So the two specialists, they need to confirm that the continuation of the pregnancy will harm the mother as well as the baby. So that is the condition. So number two, hematological malignancy. If the bone marrow is hypocellular, is there a need to prepare how many minimal cells number? Yes, I think this is a big challenge for I think for us also in our lab, where many times the bone marrow is hypocellular. I am not sure what is the minimum number of cells, but normally we will just try to harvest the cells. For example, each time a bone marrow is being taken, cytogenetics lab, who will be there, who will be present during the bone marrow aspiration in the ward, and then they will pass the bone marrow straight to the technician, who will then carry it to the lab, to the cytogenetics lab. So even if it's hypocellular, we will still try to harvest, to culture the cells. So I do not think that we have a minimal number of cells. But again, I need to check this. We will always try, because it is not easy to get bone marrow sample, especially in cancer patients. And it is very traumatic as well, especially for children, for babies. So we will try to help, and we will try to culture, to harvest the cell as much as possible. I hope that answered the question.
If if the bone marrow type blood from peripheral, okay.
Yeah. Yes, you're right. Yeah, we can also use blood. So also we will also proceed, and we will try to culture using blood, which may not be as accurate or as specific as bone marrow, but we will inform the doctor that yes, we have no choice. You send us blood. We have done this blood, and this is the best result that we have, and the doctor will try to use this minimum information to help in the treatment of the patient.
So there is still alternative if the bone marrow is hypocellular.
Yes, yes.
Okay, thank you for your answer,
Yes.
Prof. Maybe still next question. Okay, Prof, what is the difference between carrier and predictive testing for genetic screening? Which one is more important? Carrier or predictive risk for disease, Prof? Thank you.
Yeah. So so I think it depends. It depends on what is our aim for the screening. So if if we do a population screening, for example, for thalassemia, so we want to find carriers, because carriers are normal people, normal-looking people, and we want to provide counseling for them, or awareness for them that they are carriers. They should not marry carriers. So then, we need to aim for carriers. So of course, if predictive testing, I think, is when you need to, you need to be more specific in what you look for. So normally for population screening, I think the aim is to look for or to identify carriers, or to tell the population, or to allow the population to identify themselves. So those patients, so those carriers can then contact their other family members to get the other family members to be screened as well for carrier. So so I think that is for the carrier screening. Now, predictive testing is more when you look for the group of patients or the group of population which are affected by the disease and which requires a particular treatment. So carriers normally do not require any particular treatment. They just need to be aware that they are carriers and the risk, what risk that they carry. So I hope that answered the question.
Yes, thank you. Thank you for your explanation, Prof. Is still
Yeah.
next question? Okay. This is so many questions, Prof.
Okay.
Your presentation is very interesting because, Prof, so there are so many questions. The next question from Dr. Iva about how far can genetic screening test detect condition in children? And will it be a mandatory screening test in newborn baby in the future?
Yes, yes. Thank you. Thank you. Walaikum salam, Dr. Ifa. For the second part of your question, would it be mandatory screening test in newborn baby in the future? If you ask me, if I am the president of Indonesia, I will say yes. I will make it mandatory. But no, I'm just joking. So my opinion is that yes, all newborn, as a geneticist, I would advocate for newborn screening, newborn genomic screening, as I mentioned earlier. Several times I mentioned this. I believe this is the way forward. All of us, we have a right to know what of developing diseases that 20 years DNA screening and finding out. So each of us have a right to know. Maybe some of us do not want to know, but we have the means. We have the ability to know. So I would advocate for a screening for all newborn baby in the future. And then how far can genetic screening tests detect conditions in children that typically do not present until adulthood? Yes, this is one of the main reasons why we do a screening in newborn so that we can detect what diseases or what conditions will happen in the future, especially during adulthood. So Huntington's disease, for example, is a disease, a genetic disease, which occurs during adult. Similarly, the inherited breast cancer, the BRCA, the BRCA1 and 2, is also, they are inherited. They do not happen or do not occur until the age of 40 and above. So, but all this can be detected by doing a newborn screening test. So we can pick it up, at birth, and the patient will be able to prepare, knowing that they carry the mutation and the risk of developing the disease during adulthood. I hope that answered the question.
Thank you, Prof, for your explanation. And the last question, Prof. The last question from Dr. Wilma. Will the genetic testing be useful for choosing the treatment, especially in malignancy?
Yes, yes. So this is a good question. Yes. So when we do testing, the idea is to allow the patient, the choice of treatment if it is available. So, for example, in genetic disease like SMA, we have gene therapy. So it is expensive. There are several types of gene therapy. So the patient would be able to choose which type of gene therapy, from an early stage. So, also in malignancy, I think if there are treatment, so the genetic testing will then allow what treatment can be used. For example, the BCR-ABL, presence of a BCR-ABL in leukemia would then indicate that the patient will respond to a certain drug or certain treatment. So yes, so that is the idea, Dr. Wilma, why we do genetic testing, so that the patient would be able not just to know what disease he or she will develop, but also what sort of treatment that he or she would be able to receive. So that is the whole idea: precision medicine, personalized medicine, pharmacogenomics. So all this, the base is to have a molecular profiling of ours. I hope that answered the question.
Okay, thank you for your explanation, Prof. I think this is the last question. Yes. Okay. Thank you for answering and explaining all. It's so interesting about genetic testing, Prof. It's used to only for diagnostic, but now we can see that the genetic testing is developed until genetic therapy and personal genetic therapy, Prof. And it's so interesting for me to hear your explanation about we can choose the normal structure embryo for the normal pregnancy. I think now we have completed the discussion session, Prof. Thank you very much, Professor Zulfalil bin Alwi, for sharing your knowledge. I'm so appreciate about it. And for our audience, thank you for being a wonderful participant during this activity. Hopeful this learning material can improve our knowledge. Hope can see you again. Mohon maaf jika ada salah-salah kata dari kami sebagai moderator. Thank you so much, Prof. And I'm sorry if there is wrong word from me or something like that. Thank you so much, Prof. Assalamualaikum warahmatullahi wabarakatuh. Next, we return this event to MC Dr. Dayinta. Time is yours. Thank you so much, Prof.
Thank you.
Thank you, Doctor.
So
Thank you,
before,
Doctor.
sorry, can I, Dr. Dain, can I say something?
Yeah.
So I
Yes, please.
would like to invite any of you who are interested to come to USM for collaboration or for training. Please let me know if you are interested to come. Our lab is not a big one. So like I said, we do not do genomic screening, mainly because we think that it is not cost effective. It is very expensive. The machine are very expensive, and not just expensive, but also very difficult to maintain. Very, very difficult. We have many labs in Malaysia. They bought the genomic sequencer, but after a few years, this machine broke down, and it is too costly to repair this, and then it is not being used at all. So we do not have any genomic testing, but we do cytogenetic. We do cytogenetics bone marrow and blood, not amniotic fluid. We are not doing amniotic fluid, and we do molecular testing. So if you are interested to come here and learn for the students, you are most welcome. Please.
Thank you very much for your information.
Thank you, Prof. Maybe I need just time from Dr. Dayinta. I will let me say. Okay. Thank you very much, Prof. Zulfalil. And our study program will arrange some formal agreement about MOU from our university or faculty with the University Science of Malaysia. We already know that our university already have an agreement with your university, but maybe we have make a formal agreement from our program study to your faculty maybe, and then we can arrange collaboration in research, and maybe some next year I will arrange some formal agreement, and we can assign agreement from our faculty and your faculty. I already arranged it for Prof, but maybe we need some times to arrange the formal agreement. Thank you very much for the invitation, Prof. We were very happy to come to invite you for your invitation. I think our student will be very grateful to have some research in your lab. Thank you very much, Prof. I'll back to the MC, uh, Dr. Dainta.
And Professor Dilfalil bin Alwi for a very interesting lecture and discussion. Finally, we have come to the end of this guest lecture. Thank you very much to our speaker, Professor Dilfalil bin Alwi, MBBS, Master of Science, Master of Medicine, Pediatric, PhD, SAMM, and to our moderator, Dr. Meta Hendrian Imtiaz, Master of Biomedical Clinical Pathologist Consultant, our respected professor, attending doctors, residents, and all the audience. We would like to remind all the participants to fill in the attendance link, which can be accessed in the meeting chat. In this guest lecture, you are going to get an A certificate without an AD-SKP. And the honorable professor, doctors, and all participants. Before leaving the Zoom, we are pleased to take a picture together. To Professor Dilfalil bin Alwi, MBBS, Master of Science, Master of Medicine, Pediatric, PhD, SAMM. Dr. Meta Hendrian Imtiaz, Master of Biomedical Clinical Pathologist Consultant. Dr. Retno Ningrum, Clinical Pathologist of Health, Clinical Pathologist Consultant of Hematology and Immunology. Professor Dr. Banundari Rahmawati, Clinical Pathologist Consultant, and Professor Dr. Listiani Besuromo, Clinical Pathologist Consultant. Please kindly turn the camera on, since we are going to take a photo together. On the count of 3, 1, 2, 3. Once again, 1, 2, 3. To all participants, please kindly turn the camera on. On the count of 3, 1, 2, 3. Next, 1, 2, 3. Once again, 1, 2, 3. Thank you. Ladies and gentlemen, this is the end of the guest lecture today. We would like to thank you to Professor Dilfalil bin Alwi, MBBS, Master of Science, Master of Medicine, Pediatric, PhD, SAMM, as the guest speaker. Furthermore, to all participants, thank you for joining us today. Hopefully, all the knowledge that has been given can enrich insight for all of us. To all committee and participants, thank you. We do really hope to be able to see you again in the next occasion. On behalf of our committee, I would like to apologize for all the inconvenience and mistakes during the event. Stay happy and healthy. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam
Warahmatullahi wabarakatuh.
Thank you very
Warahmatullahi wabarakatuh. Thank you very much.
Thank you very much, Professor.
Thank you, Prof. Silvalio.
Thank you, Prof. Silvalil.
Thank you, Prof.
much.